Thanks for including me here. So I'll be talking on working up the visual pathway. Part of it has already been covered by the speakers. There is bound to be some overlap in the talks. So this is the visual pathway. All of you are aware of the field effects that can be produced. So can be found in almost all visual field textbooks. So it's important that you are aware of this. So before I start my main presentation, I would like to take you through all these cases. Because many of them were sent to me for neurophthal opinion. Many of them were sent to me for neurophthal opinion. This one presented with an acute visual loss. If you notice, this patient has pseudoexfoliation. So actually, there is not a neurophthal cause to it. The optometrist has written dull glow, and the PG has seen the fundus and referred it to me, saying there is no RAPD, or she's not able to assess the RAPD because the pupil itself is so small. So remember, we are ophthalmologists first and then neuro-ophthalmologists next. If you make a close slit here, this patient is aphakic. So that is because this patient has pseudoexfoliation and the bag IOL complex has dislocated into the vitreous. So I called the optometrist again, did the aphakic refraction. Patient has a vision of 6/6, referred to vitreoretina for further management. And this patient was referred as disc pallor. Note the cupping here, and the nerve fiber bundle defect is seen here, nerve fiber bundle defect. So this patient has a glaucomatous optic neuropathy. To be referred to glaucoma. And this patient was referred as disc edema. This patient had already spent quite a lot of time, had come around lunchtime, and had already spent around 3 to 4 hours waiting for neurophthal opinion. So I called the PG and requested her to take the blood pressure. The blood pressure was this much. So malignant hypertension, we have no business with these patients here in an ophthalmology setup. These patients have to be urgently referred to the intensivist or the cardiologist for further management. You keep them in your ophthal clinic, you are asking for trouble, because they can go in for decompensation. Even young patients are developing this. Very young patients are developing high blood pressure. So any patient with disc edema, unilateral, bilateral, please remember to record the blood pressure once. So this patient was again referred as optic atrophy. So if you notice, in addition to optic atrophy, this patient has generalized arteriolar attenuation, and also had a history of, I just asked one history, do you have night blindness? So the patient said yes, and this patient has a classic retinitis pigmentosa. And this patient, if you notice here, so this patient was referred with gradual, painless, progressive vision loss, referred because nobody else could pick a cause to it. So I just asked about history of flashes. So I asked about history of flashes, and the patient said, yes, I have history of flashes. So I referred the patient, courtesy Dr. Paraksha, and this patient has a flat ERG. So essentially had cancer associated, carcinoma associated retinopathy. So these are history points that we need to take. Remember that we are ophthalmologists first. Again, this patient was also referred because of unexplained vision loss. So if you ask the patient to look down, this is Munson sign. So we have traditionally been taught for our exams that if you cannot find anything, remember keratoconus, call the optometrist and speak. Of course, scissoring was mentioned and was again missed, and this thing was referred to neuro-ophthalmology. So coming to the main presentation. So this patient gave a history, 2 slides back to back. So history of headache, and the visual functions were normal. I should have included the visual fields here. I forgot to include. So you have disc edema, headache. The blood pressure was normal for all these patients. I have already mentioned the blood pressure here. So it is mandatory in our clinic that if you have a disc edema, further workup goes only after measuring the blood pressure. So you have this disc edema with nerve fiber layer fluid, and so the investigation that you need to get done here is MRI with contrast and MRV. It is not CT scan, it is not MRI alone, it has to be MRI with contrast and MRV. The reason I'll mention in the slide, and remember this sign on OCT, there is an inward pointing of the Brooks membrane. In the other condition, if it's a primary pathology of the optic disc, it will be outward pointing. So the Brooks membrane is pointing inward, suggestive of papilledema. Okay, and both cases the optic nerve functions are essentially normal. This showing some constriction, and sorry, the slide is flipped. If you see here, there's a widening of the perioptic. This is a T2 weighted image. See, the vitreous is white here. There is a widening of the perioptic space. There's a partially empty cella, and most importantly, there is a flattening of the globe, better seen in this image in a higher magnification. And if you see here, so if you see here, there is a flattening of the sclera, and there is also a bulge here. So these are all signs of a raised intracranial tension. So again, why the intracranial tension is raised? You would need an MRI with contrast. Again, I repeat here, it's an MRI with contrast and MR venography. This was an unfortunate incident that happened. Patient was referred as MRI with the above clinical signs and was treated with Diamox. The papilledema was not resolving. So the neurologist at this point of time decided to get an MRV done. This patient has a superior sagittal sinus thrombosis. So it is not worth missing this. These patients can develop hemorrhagic infarcts at any point of time. So always get an MRI with MRV done. So again, history is the key. So the patient again referred with optic atrophy had a history of craniopharyngioma excision. So our role here actually had been sent by the neurosurgeon. Only if you ask, they tell all this that the neurosurgeon had requested an ophthal opinion. No letter was given. So patient was sent to the neuro-ophthal clinic. Your role lies in monitoring by visual acuity by color vision, and any patient 8 years or above can have an automated perimetry also done. 8 years and above, you have a normative database, you can get automated perimetry now. So here again, this patient had lost vision. So it is important here. This is a traumatic optic neuropathy, very evident from the history. What is important here is you need to specifically ask them, was the vision loss noted immediately after the injury, or was it a gradual, painless, progressive vision loss? So here we had the records that documented that the vision was immediately lost following the injury. So this again, very, very important thing. You hear a lot of patients losing vision after illicit liquor consumption. So this patient also had a history of methanol consumption, possible methanol toxicity, because many of his colleagues also had consumed, colleagues of friends had consumed liquor, and they also lost sudden vision. So management, you could give them a IV folinic acid, but that's about it. Management has to be, because they have metabolic acidosis, and they can have a lot of systemic complication. They can also have renal failure. So they have to undergo hemodialysis and hemoperfusion along with IV folinic acid and IV ethanol. Paradoxically, ethanol is given for methanol toxicity to reduce the metabolism. So that has to be given, done by an intensivist only. And because of some delay in treatment, this patient only managed to get counting finger 50 centimeter vision after so many days. So again, in methanol toxicity, IV methylprednisolone has absolutely no role. So now this patient came with a sudden vision loss. So sudden vision loss and typical altitudinal field defect. So here there are some issues here. So some issues because yeah, because two speakers have not come, so I'll just take a little extra time if that is okay. Yes. So typically altitudinal vision loss. Here I want to point out that MOG optic neuropathy, MOG optic neuritis can very much mimic a non-arthritic ischemic optic neuropathy. So if the patient presents to you after 2 weeks, then you can get the OCT angio done, which can help you avoid an MRI in these patients. So if you notice here, the OCT angio is showing a segmental loss of disc capillaries. So you have an inferior loss and corresponding superior altitudinal field effect. So we managed to avoid an MRI in these patients. If the patient presents after 2 weeks, if within 2 weeks you get an OCT angio done, you will not get any information because of the disc edema. OCT angio may fail to show this loss of capillaries. So again, this is very, very important, already pointed out by speakers, by madam before me, that you need to, in any patient with a bilateral optic neuropathy, it can be asymmetric also, you need to take a history of ATT, specifically ask them. So because of this new RNTCP, earlier they used to be given HRZD for 2 months. INH, rifampicin, pyrazinamide, and ethambutol for 2 months. Now it is extended for 6 months, sometimes even 9 months they are on ethambutol. And this weight-based dosing regime that has been introduced by RNTCP has resulted in some patients getting extra ethambutol. So unless you stop it on time, so this patient is going to have a permanent and severe vision loss. So notice this. So this patient was on 8 months for pulmonary tuberculosis and was on ethambutol 1,200 gram, which was because he was taking it both from his treating hospital as well as from RNTCP. And after stopping ethambutol, he still was left with optic atrophy and a field defect, but his vision came back from here 618, 660 to 69 in both eyes. So this is very, very important. History is extremely important. Now, this is where I have burnt my fingers many times in the past. So I want to share this case with you. So pain during eye movement with some vision disturbance. So the vision is normal, color vision is normal, visual fields are also normal. But because I have burnt my fingers, optic neuritis can worsen in the first 2 weeks. So in these patients, please follow them up closely, especially if they are very particular, the pain is there during eye movement. Follow them up very closely. And this patient actually came back. MRI was normal, and he was a MOG positive optic neuritis. So if you fail to follow them up, fail to institute steroids on time, the vision loss is going to be permanent in MOG. MOG may be slightly less dangerous, but if you do not give steroids, it is going to devastate the patient. So now this patient is very instructive because we very often fail to take this history. So I had a simultaneous vision loss. Okay, it is important to know whether it's a sequential, as in Leber's optic neuropathy, or it's a Leber's hereditary optic neuropathy. It was a simultaneous vision loss and had chronic diarrhea. So we suspected that this patient had got B12 folate done, but that was way back in 2021, and this patient presented in 2022. So I had chronic diarrhea and had this vision, which was sitting at 612, 636 with zero color vision and with visual fields that was severely depressed and with an extensive ganglion cell loss. So if you see, it's a bilateral optic neuropathy and MRI was normal. Any bilateral optic neuropathy, however classic the presentation may be, please have an MRI with contrast done before you venture out into all these kind of diagnosis. So the hemoglobin was normal, but if you notice here, there could be a clue. We always get, hemogram MCV done. So MCV is a little more. Okay, it could be an early megaloblastic anemia. And if you see here, the B12 levels are low. So in combined B12 and folate deficiency, it's always important to either correct them together or to correct the B12 deficiency first. If you correct the folate deficiency first, hematopoiesis will kick in and the patient will go in for demyelination of the cord, called the subacute combined degeneration of the cord. Because B12 is given by injection, so patient may take some time taking the injection. If you give the folate tablets, patient will consume that first. And because the oral absorption is unpredictable for B12, better to give the injection first and then give the folate. So always look for orbital signs. So this patient presented with gradual painless progressive vision loss. If you see on Nafziger's sign, this eye appears to protrude a little bit. The visual fields are severely depressed. So we got an MRI done, and true enough, had a large schwannoma on the right side, had a large schwannoma on the right side. So important to comprehensively look at these patients. So the importance of diagnosing these three, as has been pointed out, is because the treatment varies so much. Already been covered by my speaker, but it is important to know that you really need to distinguish between these entities. So remember COVID always. So this patient had a history of COVID, was poorly controlled diabetic, and was referred for pulse steroids. But if you get the MRI and you see here, the patient has an invasive fungal sinusitis. Okay, so refer to the ENT surgeon, and patient did get back very good vision. So again, this patient presented with this history of sudden painless loss of vision over a week's time. The fields could not be done here, but this field is respecting the vertical midline. Okay, this field is respecting the vertical midline. So this was a large cellular mass. So even if you have a temporal field defect in one eye, take it very significantly. Get an imaging done at the earliest. So this was a large cellular mass. If you notice, the temporal hemianopia is complete only on one side. On this side, it's quite incomplete. But this patient had a very large cellular mass. So and the seesaw nystagmus is also typical of these cellular lesions. You can make the diagnosis at the bedside. So this is a pie. I'll rush through my remaining slide. This is a pie on the sky. You consider a temporal lobe lesion. So post-traumatic, this patient has a temporal contusion here. And this is a pie on the floor defect. So again, learn to recognize the 120-point screening, which can be done if the patient has come dilated to you, as often happens in a busy clinic. So pie on the floor and has right parieto-occipital infarct. So this is a very very strange thing that happened. Patient complained of left side field defect. If you notice, half sector in each eye is involved. So it's a sector anopia caused by a LGB infarct. Very rare condition that happens. This is the LGB infarct, and has to be referred to a neurologist. So if you see, this patient has extensive field defect. This field defect appears to respect the vertical meridian, and so does this. So this patient has a bilateral homonymous hemianopia. I learned this term from Dr. Andrew Lee, and has bilateral acute infarct in the occipital lobe on both sides. So bilateral usually spares the macula. And this history of malignancy is very important. So this patient came with counting fingers vision, and incidentally, when she walked, when I got up from my chair, she greeted me, and when I put my this thing on the slit lamp, she also said where she has to put. So everybody was thinking it is kind of functional vision loss. Please notice these patients with occipital lesions can have statokinetic dissociation. They can perceive moving targets. So when I got up, she wished me. So that led me also to think fundus was normal, but she had a history of malignancy. So we decided to get her imaged, and she has this chemotherapy was completed 6 years back. And if you notice here, there are multiple metastases in the occipital lobe. And what would have happened if we had just dismissed her as malingering? So multiple lesions in the occipital lobe. So remember the statokinetic dissociation. That is my last slide. And thanks to all those in my clinic at I Foundation who had referred it.